This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon, and we are back for another deep dive into the literature that shapes our clinical practice.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal World Neurosurgery, published in 2026. The paper is titled Clinical Characteristics and Outcome of Early and Late-Onset Pulmonary Thromboembolism After Neurosurgery, a single-center retrospective observational study.
This is a topic that hits home for anyone who spends time in the ICU or on the wards postoperatively. We all know that pulmonary embolism, or PE, is one of those complications we dread. It significantly elevates the risk of morbidity and mortality for our patients. But what I found particularly interesting about this paper, Alara, is how the authors challenge the idea that all post-surgical PEs are created equal.
Exactly, Dr. Aris. The core premise of this study is that PEs following neurosurgical procedures are suspected to be heterogeneous. They aren't just a single clinical entity. Specifically, the researchers focused on the timing of the event, comparing early onset versus late onset postoperative PE.
Right. And for the residents listening, that word heterogeneous is key. It suggests that the PE a patient develops on day 2 might have a completely different clinical profile than the one that hits on day 14. The objective of this study was to identify clinical characteristics that discriminate both phenotypes and to characterize their differences in clinical outcome.
It was a single-center retrospective observational study. By looking back at their data, they wanted to see if they could find specific markers that separate these two phenotypes. When we talk about early versus late, we're looking at how the clinical manifestations change depending on how far out the patient is from the operating table.
Let's talk about that discrimination of phenotypes. In our field, we're often balancing the risk of hemorrhage against the risk of thromboembolism. If the early onset phenotype looks different, perhaps tied more closely to the surgical duration or the specific pathology, it changes how we might approach prophylaxis in those first critical 48 to 72 hours.
That's a great point. The study highlights that because these events significantly elevate the risk of mortality, understanding the timing is crucial. If the late-onset phenotype is driven by different factors, maybe related more to postoperative mobility or the transition to subacute care, then our surveillance strategies might need to extend further than we currently practice.
And that's the clinical manifestation aspect the abstract mentions. As a senior attending, I'm always asking, what did the patient look like right before the event? Were there warning signs? The study seeks to find those discriminating characteristics. For example, is early onset PE more sudden? Is late onset associated with a higher mortality rate because the patient is no longer in the high acuity setting?
The researchers really focused on the clinical outcome as well. It's not just about when the PE happens, but what happens to the patient afterward. By characterizing the differences in outcome between the early and late groups, they provide a clearer picture of the prognosis.
It's a vital distinction for medical students and residents to grasp. When you're on a neurosurgical service, you can't just check a box for a PE risk on day 1 and forget it. This study suggests that the risk profile evolves. The phenotype you're looking for in a patient who is 3 days post-craniotomy might be different from a patient who is 10 days post-spine surgery.
And because it's a retrospective observational study, it gives us a real-world look at how these cases presented in a single-center environment. It underscores the necessity of being vigilant throughout the entire postoperative period, not just the immediate window.
Precisely. If we can discriminate between these phenotypes, we can perhaps tailor our interventions. The goal is always to reduce that elevated risk of morbidity and mortality. This paper gives us the framework to start thinking about PE not as a single postoperative hurdle, but as a dynamic threat that changes over time.
It definitely calls for a more nuanced approach to postoperative care. We hope this study encourages more centers to look at their own data regarding early versus late onset events.
Well said, Dr. Alara. That's all the time we have for today's episode. Remember, neurosurgical care doesn't end when the last stitch is placed. The vigilance continues through every phase of recovery.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you in the next episode.